Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Good morning, everybody, and welcome back to another episode. So today I have with us Dr. Michael Neal, who is a practicing optometrist currently in the US, and I will let him introduce himself to you.
Hi, everybody. I'm Dr. Mike Neal. I'm a practicing eye care doctor in Pennsylvania, rural Pennsylvania. And I grew up on the other side of the province from where Dr. Smith is right now. So I also have a software company called Build My Team, which is a company that's designed to find better people faster for healthcare practices.
Which is super fun. All right, so we're going to dive into what made you think that this was a great career for you.
Optometry, you mean? Like eye care? Oh, absolutely. Well, that's pretty straightforward. I've always had a little bit more of an entrepreneurial bend to me than perhaps other doctors. I love the business of healthcare. I don't know, it's a little different, I guess, but I truly enjoy it. And that was kind of something I was looking for right out of school. And I also worked in an eye care practice, fell in love with the concept of the practice. And then also, plain and simply, try and close your eyes and get around your day, right? I mean, just the concept, the science of eye care itself and the visual system is fascinating. So all that rolled into one, and I said, hey, this looks like a pretty good gig. Let's give it a shot.
Okay, perfect. Before we get to you graduating, anything about the experience of kind of getting into the learning and healthcare field that that you were maybe initially finding difficult, or your journey? Tell us about that.
Well, the way I would describe it, I went to school in Philadelphia for optometry, and I would describe it as wonderfully prepared from a clinical standpoint, woefully, ridiculously underprepared for doing anything other than working for somebody. I mean, we got, I think, one course in practice management, and that was it. The concept of trying to roll up how to run a practice in one course is nothing short of laughable. But then you get into the real world and find out in a hurry that you can learn very quickly when it's punishing if you don't. And, charts, for example, talk about punishing. Do this well, we pay you. Do this poorly, you don't get paid. Do this really poorly or unethically, you're going to jail. So, welcome to healthcare.
What did you find about the experience of charting then in your day? Was that explained well? Do you think that was covered well in the course?
Well, in the academic side of things at the school I went to, I think we had 4 or 5 pages, and they wanted documentation that was stupendous. I mean, you were writing an essay on each patient. And in a private practice, there's 2 sides to that. In America, you have to do that, but now thankfully the software does most of the heavy lifting for you. But back then it was, it was restrictive because you couldn't see many patients due to the fact that you had to write the essays. So were we, student doctors or were we student essayists? Yeah, I'd argue both, perhaps.
The people that you were learning from, do you think that I'm presuming they were within academic centers, so they weren't necessarily in there to see volume anyway.
Right.
And the rule makers around the charting were clearly not in there for the volume of patients either necessarily. Tell us about that. What do you think the difference is with your training people versus your real life experience?
Well, I can understand their approach. They have to make sure that the habits are built for creating meticulous doctors, and I understand that. Um, in a private practice that has much less um, usefulness than one would think. There, what's necessary to be in a chart? Well, I'm always looking for massive efficiencies and how to scale something. Um, it's one of the reasons why Build My Team does very well at helping clients. But on the other hand, from a charting standpoint, I'm perhaps not the best person to be in charge of that process. In our private practice, I say our because my wife and I practice together. She's much better at that stuff than I will ever be in my lifetime.
What's different about the two of you?
Everything.
Okay.
That's where I would start.
Okay, so you're finding that if you were to analyze both of your methods of containing this consultation in the documents, hers is more in depth than yours. Like you've just got the essentials. What do you mean by that?
No, I wouldn't say more in depth. I mean, we practice very similarly. We went to school at the same place, took almost all the same courses, and we are terrific from a clinical match standpoint. So
Mm-hmm.
I think she's just more thorough in her documentation. And in our practice, we pivoted years ago when we went through a process of switching EHRs. And the
Mm-hmm.
company that we were using at the time said that when we upgraded to their air quotes new EHR, we wouldn't have to punch in all the old information. Well, it
Mm-hmm.
turns out what they gave us was a PDF and it was unusable in their new chart. So they weren't technically wrong. However, it was completely misleading. We spent about 16 months re-entering every patient as a new patient, every existing as a new patient. It was a catastrophic nightmare for the practice, cost us a fortune in labor charges. And at that point, we decided we're moving to a scribe model. And now we have scribes that are in charge of the documentation for all of our patient encounters, and they sit at the other end of the speakerphone. They're still in our office.
Mm-hmm.
Well, we have a remote scribe and we have an in-office scribe, but both the scribes used to work in the office. So they sit at the other end of the speakerphone. We walk into the exam room, pop the speakerphone on, and they just take notes and document the entire exam. And that has been insanely helpful productivity wise because now we're not trying to document essays. And healthcare in North America just doesn't do that anymore. You are not, well, let me back up. I see no reason why a licensed doctor should type for a living. I flat out, you can't convince me of that. And I type incredibly well. You just can't convince me because I can either work at the level that the patients want, which is being a terrific doctor, focusing all my effort on communication with them, or I can satisfy a bureaucracy. And I find it exceptionally hard to do both. So that's why we hired an expert. They're trained. They come in without any experience, but they're trained. And the system works incredibly well.
Got it. If we went back to when you guys were documenting for yourselves, what do you think the cost was if we looked at you doing your documentation your way and wife doing her documentation her way? What do you think the cost is of the difference in that documentation?
Well, I don't know the answer to that because we pivoted with the scribes.
Mm-hmm.
And the pivot was designed to have the scribes be the leveling of the documentation. So the consistency that they bring to the table means that there should be very little, if any, um, documentation differences. So, for example, with the scribe, they they will document a little bit about what I'm describing in the exam room and what Amy is describing in the exam room, and how we describe things would be different. But otherwise, it should be very difficult to tell which doctor saw the patient.
Got it. Yeah. I'm just thinking of many of the people I work with that um, desire or expectation on themselves or a desire to get that chart note in that thorough way is costing them like evening work or weekend work. It goes beyond the day to day if you want to keep the same volume of patients, for instance, or it's just simply looks different within the workflow. So you're not got as much hands on the patient
Right.
to get as much information into the chart. So it's just curious if you had noticed any of those particular kind of differences when you got these two of you working side by side and saying, oh, look at that, Amy's still working at midnight and
Well,
I'm gone to bed.
yeah, I will say that it was a colossal fight to bring the scribes in to the mix. Some of the stuff I remember hearing, they'll never do it as well as I can. We're going to get audited. We'll get, just every conceivable reason why not to do that. But what was happening is, in business, there's opportunity cost.
Yes.
And the opportunity cost of not having people who are professionally employed to document your exams is
Yes.
gargantuan. So, you take what a doc can produce in terms of revenue wise, patient encounters. I mean, it's obviously not all about the money, but
No.
um, the
But we're looking
business
at access
ROI.
problems across North America. So if we're
Well,
not even looking at the money, if we're looking at number of patients being seen,
yeah.
then we're still talking the same thing.
Well, for example, so Edson, Alberta, where you're practicing right now, been there. It doesn't matter if you saw 10 patients, 50 patients, 100 patients, 500 patients a day, they'll want 600, 700. There's not enough
Not
in
enough.
rural
Yeah.
Alberta. Well, guess what? There's not enough in rural Pennsylvania. And we're, 2,500, what's that? 3,500 kilometers away from each other, right?
Yes.
There just isn't enough care. And
Yes.
so you can either spend your time documenting for the powers that be, or you can take better care of people. And I know why I went into healthcare. It was not in any way, shape, or form to be a slave to the keyboard and documenting these things. That is nothing short of a necessary evil,
Mm-hmm. Yeah.
but it's a requirement.
Yeah. And you can take good care of people. You're just not seeing the volume of people that need to be cared for if we're limited by ourselves. I'm so curious about this. There was a big fight that this is not going to go well. There's going to be audits that is true. Because I think that you had the external fight between two of you, but there's the internal fight, right?
Right.
Don't do this to me, you don't understand, or I can't possibly do that. That will cause troubles with regards to my patient care, my level of documentation. I mean, these are the exact objections I get when people want to do things. But I say, but if you don't do it in a new way, you're not going to have your life back. You're going to still be working till midnight every night. So we're looking
Yeah.
at what else is possible for you.
Well, I would ask your list. I'm going to tell a little story if it's okay. Um,
Absolutely.
I would ask your listeners to imagine this scenario. So um, now I'm a little different on the entrepreneurial side of things, but I also have the ability to delegate, and a lot of docs don't. I've learned that through different training systems that I've been in over the years, non-healthcare related training systems. So the old days, you take charts home, you ignore your kids, you pay attention to your kids, you pay half attention to your kids, you're not really paying attention. Now, what were they talking about again? Yeah, oh, this chart. What did I did I do this in the exam room? Did I not do this in the exam room? Just that constant struggle in your head where you're hauling half of your charts home at the end of the week and you're spending hours on them. And I have a friend who's a physical therapist who does this. The amount of life disruption that it causes. Well, here's the thing. The people doing this, they don't stop and think of that life disruption because they don't think that there's a different way to do it.
Mm-hmm.
So let's contrast this to the approach that I'm using in our practice. And Build My Team is the company that hired all these team members for us in our practice. I own the software company, but I also have Build My Team staffing our practice. Um, and when I say staffing, I mean finding these superstars to do this stuff. We still interview and or my team interviews the people as well. But what do? I walk into I'm seeing patients this afternoon. So I'm going to have lunch at home after I run on the treadmill. I'm going to put in about 10 kilometers this morning on the treadmill, which is a time commitment. It's
Mm.
about an hour for me, plus, getting ready for work and the rest of it.
Mm-hmm.
I'm going to roll into work. The first thing I'll do is I'll set my bag down. I won't open my computer, and I'm going to walk into the exam room. And I'll walk into the exam room, sit down, and start talking. I'll review the chart that's already pulled up on the computer by my team members.
Mm-hmm.
All of their imaging is already pulled up on the computer by my team members. I have to log into the software. That's where my hands will touch the keyboard. And I'll scroll down using the mouse wheel. I won't type a single thing.
Mm-hmm.
Okay. And the speakerphone will be on. So all of the discussion that I have with the patient, my entire focus is on the patient, will be documented by the scribe who's in the other room, or a remote scribe, Courtney, who works from home, who used to be physically in the building. And then I'm just trying to think, workflow wise, I'll review the chart at the end of the patient exam while I'm sitting next to the patient. All I
Mm-hmm.
do is just scroll through it. I have to refresh it, then scroll through it. I get up out of the exam room, and that's the last time I touch the chart. Okay. Now, there are some caveats to that. Let's say a surgeon wants a copy, or we're referring them. Then I will usually take another quick glance at it before I finalize the chart. In our software, we have to finalize them. That's it. I have not taken a chart home well, you know what? There is no chart to take home, right? And on the software, I'm not looking at these on the weekend. The patient encounter ends when I walk out of the room from the doctor's standpoint. Now, behind the scenes, what the team members will do is they will do the billing, and then we're not allowed on the doctor's side. We're not allowed. Now, think
Mm-hmm.
about that for a second. We are not allowed, and this is in a private practice with people we employ, to finalize the chart until we get billing approval to
Okay.
make sure that everything's done there.
Yeah.
Now, that is a very detailed, long-winded description of how I'm going to spend my afternoon. But I'm going to be able to see approximately 30 people in, what's that, 4 to 5 hours? I don't remember exactly what the schedule looks like today.
Mm-hmm.
We're in the sticks in rural Pennsylvania. We can't find experienced people to do all of this. So Build My Team brings these people on, and we're screening them to see who's going to be a superstar. That approach allows me to see double, possibly even triple the number of patients. And you think of what a doc earns and what a doc's capable of generating revenue-wise for the practice versus how much it costs to employ a scribe. The delta, the difference between those two numbers is enormous. So I hate doing charts. I find somebody, Build My Team finds a team member who loves doing it. Honest to God, like they get excited about this stuff. You couldn't, with a gun to my head, I couldn't enjoy that all day long, but they do. They like the exactness of it, the detail requirements, things like that. And now all of a sudden, you've got a team member who does something you hate. And I get to spend time talking to people all day long, without interacting much with the keyboard. It's a dream. It's a polar opposite work day versus what I was used to.
Yeah. And I think that's the stories that we like to capture is what wasn't going well, what wasn't sustainable about this model, and what what our clinicians and physicians are doing that creates more sustainable models for you. Now, I know that we talked a little bit about many of the physicians in the US are employed, about 75%. But then we've got private practice in the US, whether that be our primary care or other. And then we have many of the physicians in Canada are working, and actually some of the nurse practitioners as well are working as independent practice owners. So their income, whatever that be, whether it be in a family health care almost salaried model. So they get that fixed income per number
Right.
of patients on their panel, or that fee for service. So each patient they see, they're getting paid for. But they're now paying out of pocket for rent, lights, stuff. So we
Right.
get this suggestion that team is a good idea because then we can offload some of the not physician, not clinician work. But this is a cost directly out of pocket for the workers. So tell us about the couple of things that come up against that. One, it's expensive to hire people. People is probably the biggest expense for practice owners, and then followed soon after by rent and electricity. And then so it's expensive, and then onboarding, right? Because retaining good people obviously is a skill in itself, but then onboarding staff so that they're working at their highest level, because it sounds like you've taken your staff and you've figured out what is their skill set and how do we get them working at their max, right? So tell us a little bit about the journey of how did you learn this skill about onboarding and finding the right people and getting them working at a level that's so helpful to you, because that's a skill all of its own.
Well, this is where Build My Team was created. It was designed as a service, not initially to become a company, but it was designed to get my practice the best team members humanly possible in the most efficient way. And that applies to any practice, obviously. But we do this now around the US and Canada. We're in about 40 states plus Canada. Um, Getting back to your point, it's expensive. I wholeheartedly, categorically, completely, and utterly disagree with
Interesting.
what you
We need
said
to know
about
why.
the expensive. Well, it comes down to numbers. So let's say, for example, that what's a reasonable dollar amount for your listeners hourly? How much do they generate hourly? Gross revenue. What would you say the number is? Do you know that off the top of your head?
So if we went with just 150 an hour, I think that is a reasonable average amount for Canada and the US, not the private practice necessarily. And we've got different levels, but let's just go with 150 an hour
Right.
as a baseline average, pulled it out of the air, thin air kind of amount.
Yeah. Okay. So I'm going to attack this on two, and I use that word attack intentionally. I'll attack this on two levels. One,
Mhm.
$150 an hour is very, very low.
Yeah.
You know why it's low? Because you're typing for a living. So the first thing we're going to do is increase the gap between where you're at now and what you're capable of. Okay.
Mhm.
So it requires a mindset shift. And when I say mindset shift, first of all, you have to walk into your practice and say, it is not acceptable for me to work as an administrative team member. Okay.
Mhm.
So if you make that mindset shift right there, well, now all of a sudden, I want you to go through your day and think about all of the things you're doing that you can be replaced by somebody who's working at 15 to 20 bucks an hour. And it sounds like there's a ton of that. So now all of a sudden, you have taken something that most people will not enjoy. You delegate it to a team member that Build My Team finds for you, who's a superstar at doing the job that you hire them to do. And the way that we find these people and produce them for your practice is we screen them through a ridiculously thorough um, screening process that's designed to find strengths and talents. It's not resume based. We
Mhm.
find people who are naturally have strengths and talents in the role that you want them to do. And this is all standardized. It might sound like it's a little bit too good to be true. It's most certainly not. We've done this all around the country, and this is what the company was designed to do. So we put a person, you get a couple candidates to choose from. You interview them. The cost of this service is remarkably low, vastly lower than what it'll cost you to do on your own. And the key thing you said before was it's somebody that stays
Mhm.
because they're happy doing what you're asking them to do. on
Mm-hmm.
a daily basis. So you can train a person who likes what they do. You can train them because they're smart, and we measure their speed of learning, so we can categorically tell you they're going to pick this up really quickly. You get them doing that type of work, and next thing you know, you're not generating $150 an hour. Your revenue generation is much, much higher. And it can go, the sky's the limit. I could tell you some of our case studies, but they in a podcast, they don't sound like they're accurate or true, but they are, because in my practice, I don't do any administrative work other than when, and here's the caveat, we get an exceptionally difficult patient case coming in. We get any kid with severe or even moderate pathology. I'm going to read those charts because they're going right over to the specialist. Okay,
Mm-hmm.
I'll double and triple check those. Otherwise, no,
Mm-hmm.
I don't do that. It's not that it's not getting done. It's that I have a team member who's outstanding at it.
Mm-hmm.
And to give you an example, we used to have 14 employees in the practice. We now have 10 full-time equivalents. Our gross revenue has gone up dramatically with a headcount reduction, and all in all, the profitability has gone up a lot. Now, why? It's not because I'm smarter or anything like that. You've been listening to me. I'm obviously not. What I am is a person who can delegate, and I don't like doing what I don't like to do. And there's nothing wrong with that.
Mm-hmm.
Okay. That's another mindset shift. In addition to what I said earlier, you have to release yourself from thinking you have to do everything in your practice.
Yes.
So, some examples. I haven't opened up the doors of the practice in the morning for probably over a decade.
Mm-hmm.
Okay. I don't turn anything on in the morning. I'm not, we don't do, that's the key. We don't do the administrative stuff in the practice. The team does it all. And my focus is patient, patient, patient. So, is that something that your listeners can do? Yes. Is it going to happen in a month? Obviously not. But it's a mindset shift. There is help. Our company is designed to execute the plan, as I said, and grow your team members over time. And that's it in a nutshell. It works.
Mm-hmm. When you were in training, you said that there was no course in practice management, and that it kind of surprises me because I thought that, for instance, the difference between physicians and dentists is dentists, I'm hoping, are learning the business side of things because they are a private practice at the end of the day as they graduate, or they go work for somebody else. Like you said, I could go into my private practice, but I was built to, within my training, work for someone else, right? Because they didn't give you those business skill sets.
Right.
What was the learning curve like as you decided you wanted to go into private practice? What do you think that was? How long did that take you to understand who do I need in my team? What are they going to do for me? Like, what was that like?
Well, my arc is a little bit different than others because I was observing in private practices in school.
Mm-hmm.
Um, I worked in one in high school
Mm-hmm.
in Alberta, of all things.
Yeah.
So I spent as much time as possible in private practices, learning how, just learning as much, just being a sponge, being the
Yeah.
biggest sponge I could possibly be.
Yeah.
And so coming out of school, my wife started our practice originally,
Mm-hmm.
and it was very, very challenging, primarily because of the people side of things.
Mm-hmm.
Uh, didn't start build my team until 2007 or 2017, and that's where we made the huge mindset shift to completely pivot and and change the level of people that we were working with.
Mm-hmm.
Because before we were hiring through resumes and
Mm-hmm.
the traditional ways of trying to figure out. I mean, look, you cannot figure out if a person's good at something based upon a resume. It's not possible. And you say, well, who is this guy blabbering on about this stuff? Well, we use resumes all the time. Yeah, you do. And you're going to continue to get the same results that you're used to getting, which, if you're listening to this in the first place, you're not that happy with those results because they aren't working, right? I'm not being arrogant. This is just a description of the approach that we all take.
Mm-hmm.
And, in my practice, we used to take, because there's a better way. There's a
Mm-hmm.
new mousetrap, and it produces vastly better results. I believe it's Jim Collins, who said, you got to get the right people on the bus. Well, not only do we have the right people on the bus, we have the right people in the right seats on the bus. And my job is to put the guardrails on the road so that they don't go off the road. Let's be realistic here.
Mm-hmm.
But their job is to drive the bus as fast as they can. And as long as I keep those guardrails on the road and tell them where they need to drive to, provide them some directions, their job is to drive the bus. It's not my job. And
What was
it is all the difference in the world, and it's entirely and completely achievable.
Yeah, I like the difference. So the story of, the way we were doing it before with the resumes, and we had 14 people working for us, and now with the right people trained to do what they need to do, doing the things that they're good at, there's only 10 of them. Like that's very different. Like that is a significant difference in
It's
cost
huge.
of employees right
Absolutely.
there. And
Yeah, you've also got less people to manage. So there's less managerial overhead, which everybody always forgets, right? I mean,
yeah,
including me.
yes. And what were the differences with the patient experience when you had the 14 employees versus the 10 now? So what were people saying that like the unhappiness? So it's such a long wait. I didn't get reminded about my appointment. What do you mean there's a new change in the rules? What do you mean I have to cancel within 24 hours? Like all of these kind of patient objections to rules we're putting in place, just trying to contain the access issues. What were you noticing about the 14 and the patient experience? Was there anything that stands out?
Yeah, it went from a 3.2 rating to a 4.7 rating.
Mm-hmm.
It's
Okay.
quantifiable
Yeah.
because the team members, they know what they're doing, right?
Mm-hmm.
I mean, they have their areas of responsibility and they own those areas. And what I mean by ownership is, you've got, for example, our practice manager used to be our front desk receptionist, and she's gone all the way through to the top of the practice.
Mm-hmm.
Um, she is a billing savant. She's
Mm-hmm.
phenomenal at it. Um, where does that come from? Well, a lot of it comes from the fact that she knows how to properly check a patient in. You
Mm-hmm.
can't bill if you don't accept the insurance card, or you accept the wrong insurance card, or whatever it might be. Um, so, just using that as an example, we also have a front desk person who is able to do twice the work of. I mean, she's doing 1.5 to 2 people's jobs because
Mm-hmm.
she's outstanding at it. And we have opticians who are in similar boats. We have technicians, and these aren't just eye care specific positions. So, you say, well, what's an eye doctor know about my medical practice? Well, I know a lot. And the reason being is because a patient walks through your front door to a desk.
Mm-hmm.
They're greeted by somebody at that desk. Now, the person who's at that desk has the same responsibility in a medical practice as they do in an eye care practice or a dental or a chiropractic.
Mm-hmm.
The medical assistants, anybody who's providing help to the doctor, we have essentially algorithms that know what those jobs require in a person to be outstanding, what strengths and talents that we need for those people to absolutely be superstars at those jobs. So again, it doesn't matter necessarily if they're in eye care or optometry or dentistry. There's a tremendous amount of overlap, not entirely, but that's what makes each one specific to the profession. And we work with, I think it's 8, possibly 9 different healthcare professions at this point. And when we first started, I thought, well, there's going to be a lot of differences between them. And the answer to that is yes, there are. However, the team members who are doing the work are very, very similar. And that excludes licensed positions, obviously. I mean, a dental hygienist is not the same as a medical assistant, is not, but those types of positions are exceptions to that.
How does a practice identify what positions they need? So is that a internal, like, is it at the physician level or clinician level identifying who do I need in my practice? Like that internal audit of what am I doing in my day that I need kind of farmed out to others because it's no longer physician or clinician work? Or is it a team-based, this is what we need. What do you find is a successful way to decide what you need in your practice
Well, the
from
way
team
that
members?
our Build My Team process works, the first step in the process is to isolate the answer to that question because it's hard.
That's what I
It's
mean. It's
there are
very
different
hard to identify. Yeah.
approaches to be able to try and isolate that. So what a listener would do is they would go to buildmyteam.com, schedule a sales consultation. The first discussion with our team members is to find out who you need. Well, usually what happens is a doc is on the phone, the owner of the practice, or sometimes the owner or practice manager. And well, we need somebody who can do A. But a lot of times they need to be able to do B, and we need them to do C, D, and E. And oh boy, can't forget about F. Well, by the time you get out that far out, you're trying to hire 3 people.
Right.
Our approach is to and that doesn't work, by the way. You will find somebody who is the not the jack of all trades. They will definitely be the master of none, that old saying. But what we need to do is pare that down. So we're looking for a person who can do maybe 1.5 things. So they're going to have their main responsibility, and then when if there's free time or things are a little slow, which there's always a couple minutes scattered around the day where that happens, then they do their second responsibility. And so what our team does is clarifies that. And we then write the job description for the practice. We publish the job description to over 20 different job boards, and that's designed to get as many candidates to apply as possible. We run them through our screening process. We're looking for all kinds of things to determine what their strengths and talents are. We can even predict how they handle stress. It's unbelievably accurate. So when we get all these candidates in, we're going to reject almost all of them. In fact, approximately 97% of them get rejected. And then those finalist candidates go through a video interview, and then we send those the people who pass the video interview over to the practice. So here's the point. When one of our clients starts working with us, it goes all the way from isolating the role of the person to something we can actually hire for. And that, if you mess up that step, you're going to get terrible results because you're going to hire somebody who's just not going to be able to do the job you really want them to do. So that's done in consultation with our team members. And then on the other end of this, we send people to the practice who we already know they can do the job. It's not a matter of if they can do that. That's been isolated within about 97% certainty. And in fact, it's guaranteed on our process. What your role is as the owner of the practice is to simply pick the person you think would work out best out of the candidates we send you. That's how simple it is.
I think that's the key, though, is isolating who do I need and what will their primary role be. Because I think you're right that we get them doing A, B, C, D, E, and F. And I think that is big. And I think that comes out of, well, we do as the clinician, if we don't have the team supporting us, all of the things, including opening the door, answering the phone, closing the door, putting the alarm on. Like we are the master of, well, we think we've mastered all of it. But what I love seeing is when you can use a team member and they do it better than you.
It's all the difference in the world. They got the
time to do it.
This is the mindset shift that I just oh boy, I can go on and on about. Walk to your front door when you're opening the practice in the morning. Think, my practice, if I'm going to be the CEO of my practice just paid somebody $150 an hour to open this door. They just paid somebody $150 an hour to turn the lights on. They just paid somebody $150 an hour to run around the building and turn all the computers on. I mean, that is ludicrous. No, you have to stop. You absolutely have to stop. Or I would argue, and this is where I'll get into a big fight with the people listening to this, but I would argue that you are doing a disservice to your patients. Honestly. Yep, I would. Because now, since you're doing all this extra work in the practice, you have to say no to somebody who needs help, right? They need you to get them better. You have to say no because you ran out of hours in the day.
Mm-hmm.
How's that for picking a fight? But I mean, I'm not trying to be mean or ridiculous here, but I believe that from a mindset standpoint. So, in our practice, we're able to say yes to a tremendous amount of people. Okay, sometimes it's a little much. We can all agree on that. But we say yes because, somebody's got something painful in their eye, or, especially kids.
Mm-hmm.
Our sweet spot is for kids. We'll never say no to a kid.
Mm-hmm.
But we're able to say yes to that because I don't have to do all of those other things. Dr. Amy, my wife in the practice, doesn't have to do all of those things.
Mm-hmm.
And so, this gets to the bigger umbrella question of what are you doing during a day? Do you want to take care of people or do you want to take the garbage out? There's nothing wrong if you'd say that you want to take the garbage out. Okay. I'm not saying there's anything wrong with that. Just realize that from my perspective, you are making a conscious choice to do that, and that's okay.
Mm-hmm.
However, the other side of that, you can't burn the candle at both ends. The other side of that choice is you're making a conscious choice to say no to helping somebody who needs your care.
Mm, yeah. Or having your life back. So, doing that work that spills over into the evenings. And so now you're not having that quality time for rest or joy or exercising 10-kilometer run. I mean, think about, you're enjoying a 10K run this morning, then a shower, then lunch at home, then going to work. Like you could have just been doing all the paperwork.
But you see, I didn't even mention that because it didn't even pop into my head. How ridiculous is this, right? It's something I expect.
Yeah.
Perhaps I'm taking it for granted that I have this free time, but my team is at the office right now busting their buns. They're
Mm-hmm.
good at it. I'll give you an example. I'm not allowed, none of the docs in our practice are allowed to book an appointment.
Mm-hmm.
Okay, which is a core thing. Like every doctor who starts a practice books their own appointments at some
Mm-hmm.
point in time, right? I don't know how. I could not possibly begin to book one. I'm not allowed to because I don't know the intricacies
Mm-hmm.
of where to put the person on the schedule. And it's kind of like the Matrix movie where you're looking into the Matrix. When a skilled medical secretary is booking somebody, they are looking into the Matrix and they can read these schedulers at like Zen-like levels, right? No, we gotta keep people like me away from that because I'll screw it up. I don't have the talents and the strengths to do that properly. And so my mindset is one where I don't even think along those lines. And so when I'll give you an example, we in America we had Thanksgiving a little while ago, and so I in our practice we had Thursday, Friday, Saturday, Sunday off. Zero patient interactions for those 4 days. Zilch. Like it was a true holiday.
Mm-hmm.
And you mentioned going home and taking all these charts home and things like that. Um, here's one way to just cut to the chase. When your listeners are listening to this, grab a mirror. Look in the mirror. Do you like who you see? Are you happy with your how rested you look? Are you, because we're all running marathons here. Like this is there's no such thing in healthcare as, oh yeah, I'll just, take a light day. We'll just show up and maybe chillax, work some banker's hours. Those things don't exist. So if you're not happy with who you see in the mirror, this is one of the easiest lifestyle changes you can make to free up the one thing that none of us have enough of, and that's free time.
Yeah. Creating time. So important. Yeah. So where would people start? So if they were looking at what's happening within their clinic, the numbers, the staffing costs, the amount of things that they're doing that are administrative, is it, do you think it's that who do I need or what roles do I need? Is it, what would you suggest? Where would they start if they're in that pickle of the 14 team players and they're still doing all the lights on and things?
Yeah. Well, the first I would say is you make a mental shift that you just don't want to do that anymore. And now once you made that shift, you turn around and say, okay, well, if I'm not going to do it, how do I figure out who's going to do it? Because we
Mm.
obviously know it still needs to get done, right?
Mhm.
Um, maybe that's team members you have. Maybe it's reaching out to build my team, and getting a free sales consultation set up. I mean, there what our team members do all day long is help you walk through that problem. So the key point here is this is something that you as a practice owner would be deeply struggling with. You're looking at all the angles. Oh my God, if I screw this up, I'll end up paying X, Y, Z,
Yeah.
all these doom and gloom stories.
Yeah.
And on my on the build my team side, the person you're going to be talking to has probably dealt with this 5 or 6 times today before
Hmm.
lunch, right? So you're not alone. There's no reason to try and reinvent the wheel. You are literally not alone on something like this.
Hmm.
Um, uh, Schedule a consultation, get our team members' feedback, our experts at Build My Team's feedback, and then digest it for a little bit. See what you come up with. Have another call. It's fine. All that stuff's fine. Um, what isn't okay is for you to sit there and try and figure out how to do all of this yourself.
Mm.
You need help. But the first step is realizing you need help, admitting it to yourself. I need help. Okay,
Hmm.
great. Hooray. Now what do I do? Well, I just told you, that's the easiest way to start getting the ball rolling on achieving the lifestyle outcome that you want. Getting that free time back with your kids, or to go mountain biking in Jasper, or whatever it might be that you want to do. You don't have to be 100-hour-a-week slave to this practice, right? There's this old saying: is the dog wagging the tail, or is the tail wagging the dog? And I think that a large part of our discussion today could be summed up with the tail wagging the dog.
I like that. I like the summary of what are you whining about? Or what are you noticing you need help with? And I
Mm-hmm.
think that we're pretty good at identifying what we don't enjoy doing. So, what are you
Mm-hmm.
doing that you don't enjoy? What are you whining about the most? And then, who or what would you need to help you? And
Right.
then, how do you start to make that change? So, I know that a lot of the, for instance, family physicians in Canada, we were talking before, are being asked to now work with team. And there
Right.
are experts out there to tell you or help you figure out who do you need and like your best players, like not I need
Mm-hmm.
14 people.
Of
That's
course
going to
not.
cost me
Yeah.
a bucket load. Actually, it might only be 10 people you need. You just haven't figured out who you need yet and get the right people on the right seat of the bus. I use that all the time. Like you might
Mm-hmm.
have a person in your team and you may or may not have any ability to hire or fire them because of the position you work in, but they may have completely the wrong position on the bus. Like you've asked them to do
Right.
it 3 times and they do not do it. And then you retrain them and they still can't do it. They're on the
Mm-hmm.
wrong seat of the bus. It's
Right.
such an important, these are skills, these are leadership skills that as physicians and clinicians, we are leaders. Even if you don't want that hat, you are a leader. Even if you don't have hire or fire of staff within a practice, you are still a leader when it comes to the onboarding, assisting your assistants
Mm-hmm.
do their work in at their highest level within the environment that you find yourself right now, even without hiring new people. Just such a good reminder to us about the mindset of who's in our position and what are they doing and how could we help them work to they have much better job satisfaction when they're doing their work to the highest level.
Of course. I mean, who doesn't, right? And I just wonder with just physician and healthcare practitioner job satisfaction,
Mm-hmm.
this has made me this discussion has me thinking, well, I wonder if one of the low-hanging fruit on improving that job satisfaction is for the docs and the practitioners themselves to just flat out stop doing stuff they don't love to do. I
Mm-hmm.
know that it works with team members. We've demonstrated this throughout North America
Yes.
a whole bunch of times. But on the
Yes.
doctor side of things, well, if I contrast back to the my day-to-day experience prior to Build My Team changing our approach to who I was working with, yeah, a lot of those days sucked. They just flat out they sucked. You
Yes.
know, my the thing that was fun about them was the patient
Mhm.
interaction, but the rest of it a lot of the times flat out sucked
Yep.
because I wasn't great at doing a bunch of the things that I was being asked to do all day long.
Yes.
But you can't, as a doc, you have handcuffs on. You can't leave. You know, you are married biblically to that practice. I mean, you can't get out of there. So you've got loans guaranteed, you've got all, you know, your name on a lease, all those types of things. So
Yes.
what you have to do is come up with a new way to do it. And the new way is here. And this is the you know the key point of the discussion is if you want your life back, if you want what sounds too good to be true, well, it's most certainly not. And on the wall in front of my desk, I want to read you a quote. It's
Hmm.
from James Clear, the author of Atomic Habits. It
Yes.
says, goals are for people who care about winning once. Systems are for people who care about winning repeatedly. And I think about this often because Build My Team, we have a system that is created for winning over and over and over again. And in healthcare, we have all kinds of systems and processes, but they're mainly designed for patient care side of things. Well, the bulk of patient care is delivered by team members in a lot of practices. And the only way to get that to be great quality is through the systems and the processes and the approaches you take that are designed for winning repeatedly. So that's what Build My Team does.
Yes, oh, totally. You're talking to the talking to the converted. We build systems to help the physicians and clinicians within their day succeed day after day after day. We want that consistency of I want to create a sustainable day, and that includes looking first we look after you, and then we look wider and look at your team, and then we look wider and look at the full systems and processes of the practice. Like this is truly that deep dive, and having things like Build Your Team available to say, okay, you don't have to be the expert in finding your team. Phew.
No,
there
you
are
don't.
there
Right,
are
because
people
remember,
designed to do that for you.
yeah, I mean, our team members have done this 5 times before lunch. I use that example all the time. But you know, the company was named Build My Team because it's designed to build my team in
Mhm.
in my practice. It's centric to your practice. Um, and I think that it's bothersome for me to think in terms of we have all these practitioners out there who are struggling to achieve like they went into we went into healthcare to take care of people. I
Mhm.
did not go into healthcare to type for a living. I could have done computer stuff. I could have done, oh goodness, could have done anything. But what I want to do is to take care of people, have great conversations with folks. I'm obviously a reasonably social guy and I love that type of thing.
Mhm.
So if I have to do stuff in a practice I don't love, then that's taking away something I love to do. And
Mhm.
I'm unwilling to do that.
Mhm.
I'm flat out unwilling to do that anymore. And I also realize that me trying to do one of my team members' jobs is taking away something they love to do.
Mhm.
They get mad. And you know what? It's good that they get mad because every once in a while I need a little bit of a smack to realize that it's what they love to do. And maybe I should just butt out.
Mhm.
Um, and that the first time that happens, like, okay, well, that was an interesting little experience, but they're doing exactly what I told them to do.
Yeah.
And they're achieving the bigger picture goal for the practice, which is to take outstanding care of a whole bunch of people. So can't really get upset with them because they're doing exactly what they're supposed to be.
Yeah. Outstanding care of a whole bunch of them. And I think that's the important thing, is that we are trying to build great teams so that we can do what we want to do less of what we don't want to do, look after the patients, and potentially improve our access, which would be phenomenal, which could, on the other side of it, increase your income potentially. And if
Mhm.
it's not about the money, it's about you doing what you love and seeing the number of people who want you to see them in a more sustainable way, rather than just I'll put them in and I'll put that one in too, and I'll put that one in too, and now I'm doing all of that work at home, which is exhausting and unsustainable.
Well, absolutely. And, just pure numbers wise, I remember in school, we might see 5 patients a day and it was exhausting.
Mm-hmm.
And now our practice can see 10 times that on the
Mm-hmm.
schedule. Not everybody shows up. So
Mm-hmm.
it's very rare we have a day that busy, but it can be done.
Yeah.
And I am not looking at a single chart at the end of that day.
Yeah.
I'm not bringing work home
And you're not
because
sacrificing patient care to do it, I think, as well.
no, oh, good Lord, no. No, I mean, in our practice, we take 7 different screening images of a patient before they're
Mm-hmm.
seen in the exam room. I think, it would be tough to do that without the team. I don't think you could do that in a week. I don't
Mm-hmm.
think you could see a day's worth of patients in a week because the doc would be doing everything themselves. And so, you just 5x the amount of access that the patients have to you while simultaneously cutting your non at work workload down to functionally zero.
Yeah, yeah. I mean, we know we've got the studies that showed that adult primary care, if you were to do, the physician, all of the screening prevention measures for that patient, just the patients you saw today,
Right.
is 27 hours of work.
Yeah.
So it's beyond what you
Good
could do in
grief.
24 hours, right? And so clearly it has to be divvied out, and we want the right people on the right seat of the bus helping you.
Mhm.
It is so
Well,
good.
the process works. So I would just ask your listeners to consider if they're interested in having a discussion to see if going down this road is for them. Start the discussion.
Mm-hmm.
Go to buildmyteam.com, schedule a consultation. It's all done around your time, and see if maybe that vision, that dream that they didn't quite think is possible. Well, I'm here to tell you it's not only possible, I've been doing it for years and years. And it just requires a mindset shift and some expert help. Those are the two things that, when put together, will make magic like you don't even believe is possible.
Yeah. Well, thank you so much for this conversation, Mike. I really appreciate you being here today and kind of giving us that imagination, that thinking, that start of who do I need and what am I doing that I don't enjoy, and how could I start to make this better? So I really appreciate your time today. Thanks for coming.
Thank you very much. I loved being on the podcast, and hopefully this helps with sustainable clinical medicine.
Perfect. Thanks so much. Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.